It's Dr. Sabrina Siegel here to introduce a brand new special series brought to you by the NEI podcast. Welcome to the PsychopharmaStahlogy show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. The second theme we're addressing is on treatment-resistant depression and suicide prevention. And this time, we have some special experts on the topic joining us. Let's listen in to part 1, treatment-resistant depression and suicide prevention, hot off the press ketamine guidelines with Dr. Roger McIntyre.
Hello, I'm Dr. Andrew Cutler, Chief Medical Officer of the Neuroscience Education Institute. Welcome to another episode in our podcast series, the PsychopharmaStahlogy Show. Today's episode is particularly interesting. It's on treatment-resistant depression and suicide prevention, and we're featuring something that's hot off the press. This is ketamine treatment guidelines that literally were just published online in the American Journal of Psychiatry. With me today are Dr. Stephen Stahl and Dr. Roger McIntyre, 2 of the authors of these guidelines. Hello, gentlemen.
Hey there, Andy. Good to be with you.
Good morning, good afternoon, whatever time it is for you.
Yes. What I want to do is start out with the fact that obviously rapid treatment of depression is becoming pretty commonplace now, and certainly a lot of our clinicians are familiar with the use of ketamine and intranasal esketamine. There are certainly other things in development, such as psychedelics, which we discussed in a previous podcast. But maybe we'll start out. Roger, you're first author on these guidelines. Can you just tell us a little bit about these guidelines and what they entail?
Absolutely, Andy. And we all know that there's been interest not just in our medical profession, but also in the media, I think in the general public, certainly in government regulation around ketamine and esketamine. And esketamine has been approved by FDA not only for treatment-resistant depression, but also for depression with suicidality. Certainly speaking for myself, I was certainly excited about this new opportunity. I was also equally concerned about implementation. In other words, this is not just another medication. This is a very different type of medication. And there were specifics as it relates to the infrastructure, the type of clinics, the personnel, best practices, measurement, and so on that I really thought we needed to have some consensus on. So we put together a team, almost 2.5 dozen people around the world, so a very global perspective, to try to not just only synthesize the evidence and reviewing the pharmacology, but also come up with some agreed upon best practices, how we can do this deftly, safely, and appropriately for our patients.
Yeah, you certainly have a who's who of experts in the field of treatment-resistant depression. And I agree, ketamine clinics have been popping up, certainly all around the U.S., and I assume elsewhere. And to some degree, it's been like the Wild West. There hadn't been a lot of consensus guidelines to help us. There was one series was published, I believe, by Jerry Sanacora and others back in 2017, but this one really updates with a lot of new information and new knowledge. Steve, what's your take on these guidelines and how they might be helpful to clinicians?
Well, they really tell the state of the art and the state of the evidence. The problem with this is that ketamine itself is used off-label since it's not really gone through a formal FDA approval process for depression. And esketamine has, but the question is, which of these is being used more? And the other problem, I think, is that the people don't really understand the safety yet because the trials were small. Everybody's hungry to get this out because it was excitement. And so there's a lot of questions that came up and that most people agreed when we went through these guidelines and consensus that we have to be just cautious about what we don't know because usually the hundreds, if not thousands of people that are studied for approval, none were done for ketamine and only a few for esketamine. So it's really on the safety side that we don't quite really know everything yet.
Well, certainly, I think a lot of clinicians hear the word ketamine and get a little bit step back, if you will. Certainly, they might be familiar with it as an anesthetic. It's something we learn about in school. And probably most clinicians don't have a lot of direct experience. Roger, I know you have a lot of direct experience through your Canadian Rapid Treatment Centers of Excellence. Can you tell us a little bit about what it entails and how it's different from other uses of ketamine?
Absolutely. And we have plenty of experience now, especially with the intravenous racemic ketamine, as well as now the esketamine, the intranasal esketamine. I think what's really different about this is the personnel that's required, insofar as, at the very least, we want people who are at the point of care, who have an expertise in assessing and managing people with mood disorders. And secondly, there needs to be at least some level of competencies as it relates to monitoring patients. Some patients could have an increase in blood pressure, increase in heart rate. There could be also some other side effects like nausea or even dissociation. These tend to be relatively mild. Very infrequently would it be a reason for treatment discontinuation, but they do require monitoring. And in fact, the esketamine formulation does have a REMS, a risk event mitigation strategy, which does require surveillance for up to a couple of hours. So I think what's different is, of course, the REMS, but I think more broadly, the infrastructure and the framework is not just take a pill and go home by yourself. This does require careful assessment before, during, and after, not only of the target symptoms like depression, but also emergent adverse events like dissociation, as well as some of the physical side effects, which, good news, our experience has been, we reported on this, is very well tolerated by most patients, but it does still require monitoring. So that's a very significant difference at the point of implementation.
Steve, we're throwing around the terms ketamine and esketamine here. What's the difference? In particular, what's the impetus to develop esketamine as opposed to ketamine?
Well, the pharmacological difference is what I call GOK. God only knows. It is a racemic mixture, and you can get a patent on one of the racemates and one of the enantiomers. And so that is really the reason that the esketamine came about, because the mixture is actually off patent. Mm-hmm. There's a lot of conjecture about what the difference is in the pharmacology, and also whether or not the other enantiomer, which they are, is also potentially a drug as well. Mm-hmm. But quite frankly, the real reason for the esketamine had more to do with patent than it really had to do with pharmacology.
There's also a difference in the potency and the ability to deliver this intranasally versus IV, although I agree with you.
Right. The question of drug delivery is always there, and going intranasal is something that is not well known in psychiatry, and bioavailability is better than it is if you take it orally or even sublingually, but not as good as IV. And the other thing to note is that it's not so much the drug, it's the dose and the delivery. Mm-hmm. So what we've really learned a lot about is that the same drug given differently is a different drug. So if you slam people with a big oral dose and you take it at a party and that's ketamine, you get the maximization of dissociation, which is the goal of taking it that way. If you give it at a high intravenous load, you'll go to sleep, and that's called anesthesia. And so if you give it at a lower degree of occupancy, sub-anesthetic, you generally avoid the dissociation, but the dissociation is as a product not only of the level, but of the changing in the level, particularly when people start to come down. If they come down rapidly, they dissociate more likely than if they basically softly land, which is what you're trying to do with these dosage forms.
Mm-hmm. Roger, Steve mentioned earlier that there has not been a whole lot of data and research, not a whole lot of patients exposed, but maybe you could just briefly tell us some of the evidence for the efficacy of these drugs for TRD.
Yeah, absolutely. And if I was to do just a simple number count, we're now north of a dozen randomized controlled trials with IV racemic ketamine, which are usually studied in an acute paradigm. So a person is acutely ill, and they receive typically 4 to 6 treatments approximately across, say, 2 to 4 weeks. And then the investigator will report out the finding. Usually it's reported at 1 day, and maybe at some later time point, like 2 weeks or 4 weeks, as an example. Intranasal esketamine has a more complicated and more sophisticated development because it's been sponsored. It has an acute development program. It also has a maintenance development program in treatment-resistant depression. I think it's also noteworthy that along with its development, that is esketamine in treatment-resistant depression, it's also been developed in adults with depression and suicidality. And in fact, the FDA has provided an approval for esketamine not only in treatment-resistant depression, but depression with suicidality. And so taken together, the IV ketamine has really not been sufficiently studied from the point of view of maintenance, but certainly the esketamine has. That's a significant difference between the two formulations and delivery methods. What's interesting, though, recently what we did was, in a separate paper, we meta-analyzed the data sets. This is the proverbial trying to compare apples to oranges. I've always believed if you want to know which team's better on the basketball court, they should play each other. They shouldn't have indirect comparisons. but if you just use effect sizes at day 1 or day 7 or day 28 as a imperfect, but at least the best we got way to compare apples to apples, right now, the evidence around IV ketamine versus esketamine, which one's better in the acute, it's not really compelling one way or the other. My instinct, simply based on bioavailability, would be that IV would have the lead. The angels of evidence-based medicine would say, the evidence is not as compelling there yet. That still needs to be looked at. Someone has to do these types of head-to-head comparisons. But what is clearly the case is that ketamine and esketamine have a relatively brief duration of action. In fact, the relapse occurs within 2 to 4 weeks in a significant percentage of people. Therefore, you do require maintenance. So I think esketamine has the advantage in the sense it does have the maintenance evidence base to support its ongoing utilization.
Yeah, it does also have the advantages you mentioned of being FDA approved in the U.S. I know it's being approved in other parts of the world. And perhaps there's somewhat of a easier way of administering it, somewhat less onerous to patients.
Can I ask something here that sounds like a blasphemy coming from a confessed psychopharmacologist? And that is, why is there not more work on this drug in what happens during the ketamine experience? We're seeing, as Andy talked and as Roger knows in previous podcasts and so forth, when you give some of the psychedelics, you're having some sort of a semi-controlled psychological, if not psychotherapeutic environment. I know some of the ketamine infusions that have been reported in the literature have done that, but it hasn't been controlled in the trials. I could even ask my compatriot, Roger, what do you think about doing more of that? Is that something that is in the future, or is that leaving it uncontrolled as it generally is okay?
I think that's spot on, Steve. I think that there's good reasons to believe that incorporating a psychosocial intervention around the time of receiving ketamine or one of its derivatives or metabolites makes great sense. There's a small yet really rigorous body of data showing that a single dose of IV ketamine with a manual-based psychotherapy could be helpful for drug and alcohol misuse, which is very interesting. We are, at my center, we've just submitted a grant to incorporate so-called guided internet-based CBT with ketamine to see if we can reduce suicidality to a greater extent and sustain the effect. So I think that where the science is on pharmacology, you're right. There's been a lot of excitement around psychedelics, psilocybin, ibogaine, ayahuasca, and so on, LSD, incorporating it with fairly extensive psychotherapy, and that work is interesting, and we're looking forward to seeing where that goes. But certainly there is, I think, a relative lack of studies incorporating psychotherapy. And if we believe the conceptual framework that ketamine is, or esketamine is facilitating synaptogenesis and synaptic potentiation, to me, that seems like it's priming the pump for good psychotherapy to be incorporated.
And there may be a sweet spot right after the infusion in which you can exploit the neuroplasticity for a greater gain. Whereas if you're just in an undirected way, you don't know when those synapses are forming 20 minutes after your ketamine infusion. What's the learning that's in there if you just leave it up to randomization and nothing being controlled?
That's right.
Yeah, I've always conceptualized psychotherapy as a biologic treatment anyway. It's working on rewiring things. So maybe this is a way of jumpstarting that and boosting it. I totally agree. Now, you mentioned, Roger, synaptogenesis. I'd like you maybe both to weigh in because I think this is an emerging field and to some degree controversial or not settled. And that is, what exactly is the state-of-the-art understanding of the mechanism of action here of ketamine and its metabolites?
Yeah, I think Steve's acronym of God only knows, GOK has to be the immediate response. There is a suspect in the suspect line here, and in the NMDA receptor. This is one of the classic ion tropic receptors for glutamate is, it's a fast spiking receptor. And the theory has been that these NMDA receptors that are on these fast spiking GABAergic interneurons are what's blocked, and that indirectly leads to this glutamate surge, which then stimulates the other glutamate receptor known as AMPA. That sets in motion this cascade of events, and everyone's heard of BDNF, brain-derived neurotrophic factor, but there's another kid on the block called the mammalian target of rapamycin, mTOR, which is better known as, and these ones light up, and that leads to synaptic plasticity and synaptogenesis. That's one theoretical framework. But I think the way I look at this is that there are so-called high affinity targets, and there's lower affinity targets. Certainly the glutamate system is a high affinity target, but other lower affinity targets, depending on the dose, to Steve's point, could include monoaminergic systems, opioidergic systems, cholinergic systems, maybe even some of the calcium channels and so on. So there's quite a few receptor systems that may be a little lower affinity. But I don't know if, Steve, you had a thought on that.
Yeah, one of the daggers through the heart of the theory that has been classically put out there, which you've just articulated, is that if you block rapamycin, the mTOR pathway with rapamycin, you should be able to stop the antidepressant effect of ketamine. And that's been done in humans with depression, and it doesn't work. In fact, it makes the ketamine effect more better.
Right.
And that was done recently and published by the Yale group. And wow, that gets your head scratching. And so some people think that it might have to do with, like you say, off-target things of lower affinity. There's the idea that some of these glutamate receptors are actually where the action is. And so it's not really the downstream stuff. It's the stuff right at the NMDA receptor. All we can say is we don't really know. And you had mentioned one that's a hot topic. Is there something about mu-opioid action, which is necessary or sufficient? Probably not sufficient, but maybe necessary. And one of the other things that's coming up is that there is a dimerization or a partnership, if you will, between the mu-opioid receptor and the NMDA receptor. They hate each other. Mu agonism actually enhances NMDA antagonism. So is that one of the reasons that they work? And is mu actually in this sense favorable and good thing to have? So we've got a lot of questions, but not a lot of answers.
So in essence, perhaps this is the ultimate multimodal agent. But again, it's an evolving field of our understanding. What we do know is it works, and it works fast. And the effect doesn't last, unfortunately, as we heard. We've talked a little bit around, and certainly the topic of this podcast has to do with suicidal ideation. So what does the research say about both ketamine first and then intranasal ketamine on suicidal ideation? Roger, you want to start that one?
Yeah, sure. And this is such obviously a critical issue. We know that suicide completion remains a serious public health problem, and there's been rising rates of suicide completion across America during the last 2 to 3 decades. Now, that's not to be equated with depression, but we do know depression is the mental disorder most often associated with suicide. And it's interesting because of all the FDA-approved agents for major depression, none of them prior to esketamine had been approved for depression with suicidality. And what the evidence indicates now, and there's been a wonderful review just in the March issue of 2021 in the American Journal by J.J. Mann's group, really indicating that esketamine and ketamine clearly reduce suicidal ideation. That is very clear. There's a reduction in suicidal ideation. What's also clear is that we don't yet have evidence that they reduce suicide. And that's not because it's been looked at. It's just because it hasn't been the primary outcome in a study. So if we think about suicidality broadly, I like to think about it in, is it suicidal ideation? Is it suicidal behavior? Is it suicide? Those are 3 related but very different entities. There's clearly a reduction in suicidal ideation. That's unequivocal, and that's been subjected to various analyses. What we really now need to do is do the studies to determine whether it reduces suicidal completion. Ultimately, that's what we want to see. Yes, suicidal ideation predicts, suicidal behavior predicts suicide, but I think most will know the predictive value is still quite low. And so therefore, we need to do the studies in suicide. And there's a number of groups that are beginning to look at that. So it's extremely promising. And what's also promising is that 2 parts. One, that reduction in suicide ideation occurs very quickly, like within a day or two, which is important. But there's something really conceptually, I think, strong about ketamine and esketamine that gives you the reason to believe. It seems to have an anti-impulsivity effect. Mm-hmm. And there's been a number of evidence lines to support that. What I often tell people is at least half, if not more than half, of people who commit suicide decided, I say decided in quotes, 2 hours ago to do it. It's a highly impulsive act. Mm-hmm. The treatments that we currently have that have been shown to be anti-suicide are lithium and clozapine. What they share in common is anti-impulsivity. So it's a conjecture, it's a hypothesis that maybe the anti-impulsivity of ketamine maybe confers some anti-suicide effect.
Steve, what do you think about this topic of using these drugs for suicidal ideation?
I think it's a great frontier. And one of the problems you get in is with regulations. So that, Roger, correct me if I'm wrong, but I don't believe there's actually any approval, even though it works for suicidal ideation. In fact, right. The study of esketamine didn't actually reduce suicidal ideation in that study, but it made the depression better. So it leaves the possibility for the naysayers that maybe what's happening is that the suicidal ideation and possibly suicide are improved by improving depression. And the approval that recently came out was that it doesn't help your suicide, but if you have suicidal ideation, your depression gets better. Right. Extremely confusing, of course, because what we want to do is decrease suicide. And I actually agree very much that this is about impulsivity. The reality is that depression's not an impulse. It lasts a long time, maybe months or years or forever. But suicidality or suicide is an impulsive act. And so if you could break that for the duration of the impulse, very often the impulse won't come back. Mm-hmm. And so the nature of these infusions is a real nice setup for being able to rapidly get somebody to an infusion and stop that impulse. And then maybe the depression will respond. Maybe it'll respond at a different time course. But the impulse to kill yourself will go away. So we have to study this and make sure it's not merely the consequence of having the depression get better, but maybe something that's completely an independent mechanism.
I can imagine a paradigm shift where centers would specialize, or maybe in, say, emergency rooms or psychiatric acute care centers, where these treatments could be administered and people could be monitored for a while, but then sent home rather than being admitted for several days to weeks at a time.
Roger, in Canada, do they pay for this? It really gets down to it because it's not approved. I think that you're right, that the evidence for diminishing suicidality is great. So the question is, should we withhold this from patients and not allow them or even try to encourage them to get in to get an infusion? Problem is, would it get paid for because it's not approved?
Yeah, it's a great point, Steve. In Canada, we do have universal Medicare, but we don't have universal pharmacare. So the access, especially access to novel treatments in psychiatry, all of the frustrations and challenges and barriers that all my colleagues across America experience, you can copy and paste that here in the great white north of Canada. It's the same. Mm-hmm. And unfortunately, the public payers across Canada have not been covering it. And there's some private coverage, of course, and a lot of these things, I think we all know how this works. It depends on your private payer and your policy and things like that. But the coverage has been a major problem. What I hope, and this is maybe me being a little bit maybe connecting dots or perhaps being overreaching here, but I won't apologize to overreach. But here's what I hope. In the wake of this mental health crisis called COVID-19, where there's been greater attention now paid to mental health and suicide, which is rising in some countries, notably Japan, a few others, I wonder whether or not there might be the political climate more favorable to really prioritizing mental health, especially treatments like we're talking about that can affect depression and suicidality. So I hope the climate is more favorable for us. But right now, we have a real challenge with access.
Amen to that. PsychopharmaStahlogy podcast listeners know how effectively Dr. Stahl's books improve their understanding of a complex field. Good thing there are so many publishing this year. Like the 7th edition of the Prescriber's Guide. It's out now in paperback and spiral-bound formats and features 9 new compounds, injectable and transdermal formulations, and updated warnings and indications. or the long-awaited 5th edition of his textbook, Stahl's Essential Psychopharmacology. It includes over 500 new or refreshed figures, an intuitive color scheme, 14 new uses for older drugs, 18 brand new drugs, and much more. Not to mention a new handbook, Suicide Prevention, with Christine U. Moutier and Anthony Pisani, Practical Psychopharmacology with Joseph Goldberg, and many more titles. Visit cambridge.org/NEI to learn more and get 20% off your order. I just want to clarify, we've talked around a little bit the approvals here. Intranasal esketamine has two distinct approvals, as we've mentioned. The first is for treatment-resistant depression, TRD, where you have to fail at least 2 different antidepressants in the current episode. The second one is for depression, not necessarily TRD, with suicidal ideation. And what's interesting is, as Steve mentioned, the suicidal ideation was a secondary endpoint in that study. It did work for the depression in that severe population, but I don't know that study was designed or powered to really answer the question here about suicidal ideation. And certainly, as Roger said, meta-analyses suggest efficacy.
Yeah, that's right, Andy, the way you just described that. And the study was looking at reduction on a depression scale, the MADRS, for example, rather than being powered for SI. Steve was right. It's interesting that in that study, there was a scale used that wasn't as well known that they used to track suicide. Most of us, of course, know the Columbia scale. There's a few others like the Beck scale and so on. Mm-hmm. There was a validated scale that was used, and a very good scale, a very good psychometric scale, but it wasn't one that I think is as well known, but it didn't separate from placebo. But your point's well taken. That could be a power issue. But if we step outside of that development program, there are certainly other lines of research that do indicate that there's anti-SI effects. For me, look, I think we all welcome anti-suicidal ideation, anti-SI. I think we very much welcome that. But to be, I guess, devil's advocate, that clearly is not reducing suicide. And that's a very different game. And I think that, as we talked about, I think there are reasons to believe here that this agent could reduce suicide. And going back to what we talked about, the wraparound here being maybe a psychosocial intervention. CBT, for example, not just in person, but internet-based, has been shown to reduce depression. And it's also been shown to reduce suicidal behavior. So it'd be cool to incorporate the psychosocial intervention. It takes longer to work. That decreases the behavior, maybe CBT or dialectical behavioral therapy, with a rapid onset treatment that can reduce SI and really light up your synapses and so on. So there could be some conceptual and practical complementarity there.
Yeah, and getting back to the payment issue, sometimes traditional CBT, there's a payment issue, but maybe online might be a little
yeah, exactly.
Well, the interesting thing is that not everybody who has suicidal ideation goes on and kills themselves. And it's right. The question is, who among them will? And I've seen data suggesting that maybe 50,000 or so, maybe up to 100,000 people actually kill themselves in the United States. But 1.2 million make plans and attempted suicides, and 3.5 million made suicidal plans, and 12 million had serious thoughts of suicide. So if you talk about treating 12 million, the real question is who's the 1 million that attempt and the 100,000 that succeed? And to Roger's point, some of the studies suggest that maybe there's at least a couple 100,000 that had no plans and attempted suicide and did it completely on impulse 2 hours beforehand. So it's a complicated thing, and we could start at the outer rim, which is everybody who's got a thought of suicide, but unless it actually penetrates to that really core group that we're after, is the 100,000 or so that actually do kill themselves, it's going to be hard to say that the therapy is that useful.
Yeah, that's such a nice point. What's interesting about this, and this is critical to interpreting the data and designing studies with ketamine and esketamine, and that is that we have literally over a couple of hundred, in quotes, risk factors for suicide. Now, being male is a risk factor for suicide, but we're not going to lock into hospital all of males in society. Obviously, the question is not, is it a risk factor? To what degree does it have predictive utility? Mm-hmm. And every healthcare provider who works in mental health knows full well that in 2021, we have just about zero capability of predicting suicide. And in terms of boots on the ground prediction, you can do some mathematical models, but that doesn't really give you good predictive utility. Maybe artificial intelligence, machine learning, maybe that's our great savior for the future. Who knows? But that's clearly a problem with trying to interpret the anti-SI studies, extrapolating them into anti-suicidal behavior.
Yeah, that's a really good point, because you even know in the malpractice arena that when someone dies, they like to sue the hospitals and the doctors involved because they think it can be predicted.
Yeah.
But people don't realize that even though as a public health approach, it can be prevented. In other words, if 90% of people who kill themselves have a mental disorder and most of them are untreated, there is going to be prevention if you get people into treatment. You're not going to know who, you can't predict who you're going to prevent, but there's a public health service that you're going to, in general, prevent. So we're more into prevention than prediction, but that doesn't really help you when you're doing a clinical trial with a drug.
Certainly true. We've talked about efficacy quite a bit with ketamine and esketamine. Let's shift gears and talk a little bit about safety. What are the major categories? And Roger did allude briefly to this earlier, but what are the major categories of side effects and risks that we have to be aware of with ketamine and esketamine? Roger, again, do you want to start?
Yeah, so there's a few categories I'll just maybe highlight, Andy. The first category for me is what I just call psychiatric adverse events. Mm-hmm. The second category would be neurologic cognitive. Third would be hemodynamic. Mm-hmm. And then a fourth one we can maybe speak to is abuse liability. Mm-hmm. On the psychiatric, the most replicated adverse event is dissociation. It occurs in at least half, if not closer to 3/4 of people in some studies. It's quite common initially, but it tends to attenuate in its severity, its frequency, and duration with each treatment. And it's very rare that it leads to treatment discontinuation. So it's common, but doesn't appear to be a deal breaker. Psychosis is certainly possible with ketamine, but vanishingly rare. Right. Does that ever happen? In fact, there's an interesting small number of studies giving ketamine to people with psychotic depression with safety and efficacy reported. For example, Jerry Santacora's group at Yale. So if we move to the neurologic cognitive side effects, this is the part that's interesting. A lot of colleagues have a working view, probably because of their experience with patients who abuse ketamine, that ketamine can interfere with cognition. It turns out that these sub-anesthetic doses that we give patients, they don't interfere with cognition. In fact, there's a story unfolding. They may even benefit some measures of cognition. So that doesn't seem to be too much of a problem. I mentioned hemodynamic a little earlier. Not uncommon to see an increase in heart rate or an increase in blood pressure. Depends on the study. Between 10 to 50% of patients will have it. But again, it doesn't seem to be severe. It doesn't seem to be something that is requiring treatment discontinuation. It is one of those types of side effects that does tend to recur with subsequent treatments, unlike dissociation, which kind of attenuates. Right. So those are the major categories. One of the aspects we talked about earlier was what's the mechanism of action, and one of the targets is opioids. And there has been a legitimate question raised about, is this drug abusable? Is there potential gateway activity that's primed? And no one's unaware of the opioid crisis that took place and is still taking place. And what I would say is that both ketamine and esketamine, they are associated with drug liking. So people who take it report positive experience on it. So there's liking. But that doesn't translate so far into any type of misuse or gateway. And just to be clear, ketamine was first FDA approved in 1970. This is not a new kid on the block. This has been around for 50 years. And so one would be certainly on reasonable ground to assume that after 50 years of utilization across very different patient populations, if there was that concern at the population level, we might have seen a signal by now, and we haven't seen that. So we remain open-minded, but the data, fortunately, is not saying that it has an abuse liability.
This is not going to go away, though, as a question, particularly because what's waiting in the wings are two drugs that also have some mu-opioid and NMDA action, and that's including dextromethorphan, either combined with quinidine or bupropion, and also the inactive or the less active enantiomer of methadone called S-methadone, all seeming to have rapid onset, orally administered, though, antidepressant effects. And the question is, will their mu actions combined with NMDA actions cause more liking even than ketamine?
So yeah, I absolutely agree. And obviously this comes up quite a bit when I'm speaking to other clinicians about this topic. The issue does come up. And I think as these drugs are administered more broadly, then potentially we do have to watch out for that risk. But going back, if I could, circling back, Roger, to some of these categories you talked about, it is fascinating to me that two things about dissociation. One is that it's not necessarily required for the therapeutic efficacy because, as you mentioned, not everybody gets it and not everybody gets it every time. So certainly that's a little different from the psychedelics where you expect to have that experience for the therapeutic effect. And the other issue is that you mentioned intranasal esketamine is not contraindicated in patients with psychotic depression.
No.
So it's really fascinating.
Yeah, it really is. I think one of the challenges we have with dissociation is we're only as good as our measures. And in most clinical studies with ketamine that have been conducted and its derivatives, the scale, the clinician-administered dissociative state scale, the CADS, has been used.
Yes.
And that's a scale that was validated in assessing for dissociation in PTSD.
Mm.
So in many ways, it was repurposed as a drug safety measure in ketamine trials. Mm-hmm. And so it was a repurpose of the scale, but not its organic position. And there is a consensus in the field that the CADS is certainly better than nothing, but doesn't capture the conceptual multidimensionality of dissociation. I've been of the view, and certainly in my read of the literature, my own experience, is that the CADS doesn't really give a full estimate of the dissociation. It's more common than measured by CADS. But that being said, it has absolutely been our experience that dissociation is rarely something that leads to treatment discontinuation. And as you said, It doesn't seem to be required for patients to have a beneficial effect.
Yeah. And circling back to the neurologic effects, certainly that issue of cognition is important. And there have been reports of people who abuse ketamine at high doses who have cognitive impairment, but this is a whole different animal, as we've talked about.
Yeah, absolutely.
And the other thing about that is, in my experience, patients frequently do get quite sedated, and sometimes they'll nod off for a little while and take a little nap. But again, it is transient, clearly. And
it brings up this possibility from a pharmacological point of view that you can separate the sort of mental effects from the neuroplastic effects.
Mm-hmm.
I've seen data on the psychedelics, for example, that suggests that at sub-psychedelic doses, they're still neuroplastic.
Mm.
At basically dissociative effects of ketamine, they still could be neuroplastic, although we as pharmacologists are always interested in dose-response curves, and this is a silly, kind of funny notion that you can have better effects perhaps at a low dose than you have at high dose. We're beginning to see that also with the neurosteroids, neuroactive steroids. They are anesthetics at high doses and maybe neuroplastic at low doses.
Yeah.
So we have to be careful about our dose-response curve notions with this group of agents, and possibly we can have our cake and eat it too, which means we get neuroplasticity without these sort of undesired mental effects.
Yeah, I agree. And what's interesting about that as well is that going back to this point, Andy, about the cognition, a question that many colleagues around the world have asked me is the notion of giving ketamine for 6 months, a year longer. Do they need to be concerned about brain toxicity in the long term?
Exactly.
And there are preclinical studies that have reported excitotoxic lesions in animals who've been exposed to glutamatergic drugs. And there are 3 lesions that typically are reported. One's called Olney lesions, these little vacuoles inside neurons. Mm-hmm. The other one is when you get hyperphosphorylation of the tau protein. And thirdly, when you in fact have a loss of these very valuable parvalbumin-containing GABAergic interneurons. So these 3 lesions are reported, but that's really with higher dose ketamine in animals. And we just haven't seen evidence of neurotoxicity with more subchronic or chronic exposure, subanesthetic in TRD.
Yeah. Returning to the guidelines for just a minute here, what is the recommended dosing and frequency, first for IV ketamine?
Yeah, the evidence for the IV ketamine is strong for a dose of 0.5 milligram per kilo up to, say, 1.0 milligram a kilo. We don't yet have a dose response curve, and we don't really know that 3 times a week is more effective than twice a week. So both seem to be comparable, or at least not dissimilar, I should say. Mm-hmm. So in the range of 0.5 to 1, lower doses like 0.1 don't seem to quite cut it. 0.2 doesn't seem to quite cut it. Mm-hmm. So 0.5 to 1.0 seems to be a best fit for most. Mm-hmm. And that's given, as I said, at a frequency of 4 to 6 times across 2 to 3 weeks. Depends on the center. And of course, Spravato esketamine has its own product insert recommendation, how it's dosed, 56 to 84 milligrams in TRD, a couple of times a week for a month. And then you go to a more titrated schedule, once a week for a month and every other week, once a week or every week thereafter. Right. With one little caveat, if I still got this right, is that in depression with suicidality, if I remember correctly, the starting dose is 84 milligrams. But so there are some differences in the dosing. And by the way, extrapolating from the bioavailability of esketamine and the clearance of esketamine, there's some small differences on how S and R are cleared. The dosing of esketamine would be predicted to have kind of a similar concentration in the blood with what we're seeing with IV ketamine, but that's really comparing apples and oranges.
So we've talked a little bit about how it's administered. And just to be clear, IV ketamine is administered by an IV infusion over approximately 40 minutes. Is that right?
Yeah, that's right. Yeah, we do it over 40, 45 minutes, sometimes a little slower in some patients, but 40 to 45, that's been the protocol, so to speak, that's been most adhered to. And there are a few medications that we like to hold in patients who come for ketamine and esketamine, frankly. We try to hold benzodiazepines if we can.
Sure.
We also try to hold drugs that have vasomotor activity, like a psychostimulant.
Yes.
And there were some interesting conceptual studies that appeared that naltrexone might interfere with the antidepressant, anti-suicidality effects of ketamine.
Right.
It wasn't replicated, but there was some interesting story around that. We've taken a very conservative approach. If patients are taking naltrexone, we'll hold it. There's a few others, but for the most part, most of the time, we're adding it to their existing regimen.
Right. And I think another important clinical point is to make sure that they do take their antihypertensive medication.
Yes.
Which is the inverse of the stimulant, obviously.
That's right.
So the practical issue, the practical consequence of this is that patients are going to have to spend some time at the treatment center, certainly for the actual administration, but then also for the post-administration monitoring, safety monitoring. And you mentioned the REMS program. What exactly do we need to monitor for, and how long do patients need to stay?
Yeah, and the REMS is something I think is really a good clinical practice, quite frankly, just to keep an eye on people for up to a couple of hours. What you're really looking for is just make sure the patient has a clear sensorium. We talked about sedation. I couldn't agree more. Patients can sometimes get a little sleepy, but a clear sensorium. Second, you want to make sure the patient has good cardiorespiratory stability. Blood pressure is stable. There's no sustained increase in heart rate. And it would be vanishingly rare for dissociation to continue that long. It dissipates very quickly. So really just, frankly, our experience has been several thousand infusions later. Most patients after 20 minutes are like, hey, can I leave? I don't want to wait. I want to go. But like everything else, your SOPs are guided, really informed by the worst case scenario. And so we're always being a little overcautious. What we also insist on, Andy, is that we want people not to drive a motor vehicle for at least one night of sleep.
Yes.
And we really insist that they have a loved one or friend take them home. We're fine with Uber, but they have to have a loved one with them. We don't want them in a car with a stranger on their own.
Yeah, I think that's very wise, actually. So it's interesting, again, ketamine doesn't have the labeling that intranasal esketamine has. So for ketamine, do you tend to keep people for a couple of hours as well, or is it a case-by-case basis?
It's a good question. We tend to do more case-by-case basis. As you see, there isn't a REMS, so to speak. We're using IV ketamine racemic off-label. The guiding principle is still the same. The patient doesn't leave until they have clear sensorium, their vitals are stable, etc. All the check boxes are there. Admittedly, for most patients, that's about 30 minutes at most, 30 to 45 minutes post-treatment. But for the esketamine, there is the 2-hour mandate. So we hang on for 2 hours because of what's in the label.
Yeah, that's in the U.S. Is it the 2-hour mandate in Canada as well, Roger? Because in Europe, there's not a 2-hour mandate. It's clinical.
Correct. It's not articulated the same way, like the REMS language here in Canada, but it's a similar guiding principle here in Canada.
Okay, very important. So along the lines, then, what do clinicians need to know about the actual setting, the personnel required, and the monitoring equipment that might be required to actually do this?
Yeah, I'll just jump in, Steve, if you feel jump in as well. My view is that the personnel needs to be people who are experts in assessing depression and mood disorders broadly. So that can be doesn't have to be a psychiatrist. It could be, obviously, nurse practitioners are excellent. Our family doctors are excellent. Anesthetists can be excellent. But they have to have expertise in assessing and treating depression in psychopathology. And that's a reasonable personnel requirement. We also think it's a reasonable personnel requirement, especially with IV, that you have at least people on premise who have advanced cardio life support training for the IV. That wouldn't be required necessarily for the esketamine, but at least have confidence and competency in the area. And then people who have competencies and confidence in measurement-based care. We track the patient's symptoms and side effects and safety. They have to track that. It doesn't require extensive personnel, but you made a point earlier, Andy, which I agree with. Right across North America, clinics are popping up. And look, we all welcome availability and access. These are terrible illnesses. We want people to have access. But we also want to make sure that the core competencies are there. And I think a lot of people have told me very candidly, they're really concerned about the Wild West approach here, where they send a patient to a clinic and the clinic, it's a bit like, I call it the Chipotle burrito model. They just go in and out like a burrito, and just a fast track through the clinic, and there's no expertise locally in psychiatry. I think that's not in keeping with what most would consider to be best practices.
Yeah. I think it should also be mentioned, I was an investigator on the esketamine studies and some other glutamatergic type treatments. And it's important to have the right setting, if you will, the ability to minimize overstimulation. So we would sometimes dim the lights a little, make sure the sound is appropriate, comfortable chair for them to relax in, maybe perhaps the ability to use the internet. Those kinds of things really matter as well. Little practical nuggets. Steve, I'm going to come to you here. We've talked about ketamine and esketamine specifically for depression and treatment-resistant depression. How about using it for other mental health conditions?
Well, as Roger said, one of the interesting things is a single infusion will help your smoking and alcohol and everything else for substance abuse. I don't know. It has to be replicated in lots of findings, but it could be very interesting if it could be used for that. Certainly, it's been tried in things like panic and OCD, and probably Roger knows those data better than I do. But I guess the one thing that Roger might be a little modest about is he's taking the lead in trying to clarify this being used for bipolar depression.
Exactly.
So I think of all the things that are out there, bipolar depression, it's really on the horizon as the next one. Would you agree with that, Roger, or not?
I really would. And I think when we talk about treatment-resistant depression, it's more of an adjective than it is a noun. And often in clinics, treatment-resistant depression is really referring to bipolar disorder. And I think most clinicians are aware firsthand the malignancy of bipolar depression. That's not to imply major depression is not a malignant condition in many cases. It certainly is. But taken together, bipolar depression, I've always seen as the enemy of the state. It really is. And we don't have a lot of treatments that are FDA approved for bipolar depression. And on that note, which is interesting, Steve, is that the available literature in bipolar depression with ketamine, which again would align with our experience, is 3 points. First, they're not more prone to have dissociation. People with bipolar do not report more dissociation than major depression. Secondly, they do not report more psychosis risk. And thirdly, I think what everyone's wondering is, do they get hypomanic or manic? And no, we've not seen that. And that's not been reported. There's been one controlled study, a single IV infusion study. And so, no, we are about to start, it's now been funded by the Canadian government, a study with repeat dose IV ketamine in bipolar depression, treatment-resistant bipolar depression. Absolutely. And we talked about suicide earlier. That often is a conversation, unfortunately, that's synonymous with bipolar depression.
Yeah, I sometimes say that people with regular depression attempt suicide, but people with bipolar commit suicide. To be more lethal. What about, I've also heard it being used for PTSD in some of these clinics. What do you know about that?
Yeah, and there was a really nice study just published in the last month or two in the American Journal on that in PTSD. And, it goes back to, Steve, something you said earlier. Psychedelics are being looked at. Ecstasy is being looked at in PTSD, integrated with psychotherapy. And that's really interesting and really, frankly, intriguing on so many levels. But, hey, ketamine's also looked at there, and with some very nice results being reported in PTSD, especially the report that came out in the American Journal just a month ago. The investigators had really noted significant benefit, especially in people with histories of childhood sexual abuse, which the literature shows is abuse is a serious pathogenic exposure. But all things created equal, sexual abuse, intrafamilial sexual abuse is extremely toxic And that was one group that did especially well. So we're talking about very severe, very malignant PTSD benefiting with ketamine, some preliminary work.
Yeah. And Roger, you published an article too that ketamine not only helped with depression, but also helped with the anxiety symptoms and improved functionality. And that's something we hadn't talked about is function.
Yeah, and this is something I've noticed in both major depression and bipolar with ketamine is that I think as clinicians, of course, we all know DSM and ICD-11, et cetera. But I think clinicians, what we're doing is we're informally RDoc. We're trying to treat symptoms and domains. Mm-hmm. And patients have one or two or three symptoms that are really raining on their parade and making their life miserable. And where ketamine's been really good is it's really reduced the anxious agitation. We've talked about mixed features at NEI, really good for those mixed features in MDD and bipolar disorder. Mm-hmm. And secondly, really good for anhedonia. People who just have no kind of sense of joie de vivre or sense of pleasure in their life. And so those two areas that people like the research domain criteria kind of lingo, it's these people have this sort of overactive anxiety, and then they have this underactive reward system. That translates into the clinic as fatigue, tired, lack of motivation, lack of interest, and anxious, which makes up 3/4 of what we're trying to treat. Yeah. And those are symptoms that really are cooperating with ketamine.
Yeah, I'll never forget one of the first patients I treated with intranasal esketamine described a sense of peace. That was his word, calm and peace. And he actually looked more tranquil. It was really interesting. And that was pretty rapid. Steve, I can imagine people now starting to think about their treatment algorithms for treatment-resistant depression and depression in general. How would you say they should evaluate the use of ketamine or esketamine compared with second-generation antipsychotics?
I think that there's a number of practical issues as well as algorithmic ones. I liked Roger's analogy. He must be thinking here of the NCAA tournament. He says the only way to figure out whether something works better is put them on the court against each other. Mm-hmm. And nobody put them on the court as the atypicals. I hope maybe that will happen at some point. I think what ends up happening is that when you have a little less scary type of depression, a little less chronic type of depression, and a partial response to an SSRI or SNRI, particularly in primary care, just layering on an atypical is so easy. That's what's going to happen, I think. And also with cariprazine about to launch as well in this space, and maybe others, possibly even lumateperone, you're going to see a lot of that. Now, I don't know, Roger, do you really see people outside of a trial that only have 2 failures of an antidepressant when they go to a ketamine infusion? Because that's certainly not the case in my own anecdotal experience just seeing private patients here in San Diego. So if you actually go get in an algorithm, if you will, it tends to be after several failures. And of course, failures are funny definitions themselves. Some of those are failures for tolerability. Sometimes they're not really dosed correctly. So 2 really failures may be enough, but the reality is, in my experience, 2 failures get you an atypical, 3, 4, 5 get you ketamine. Mm-hmm. Is that fair, or is that actually just what's happening and for the wrong reason?
I think that's absolutely fair. I think it's exactly what's happening. And our experience has been, despite the fact we have this TRD definition of 2 failures, most, I don't mean 51%, north of 90% of people that come to our center, they've had 5, 6, 7, 8, 9 different treatments. But again, that point being a lot of these treatments they maybe not entirely adequate, but nonetheless, these are folks that certainly would not be treatment naive. And I think that point's well taken. I think you're looking at earlier add-on sequential atypical antipsychotic before you're looking at ketamine as ketamine. And I think this is going to be a great study to compare second-generation FDA-approved atypicals for depression as add-on to esketamine or ketamine. And there's a couple of studies now that are underway that are particularly important for specialty care. What performs better, ECT or ketamine? That's obviously a very important question. That's not as scalable as the second-generation antipsychotic comparator study, which is a really cool question that will have to be done. There's been some meta-analysis of literature, but again, I agree, it's the NCAA time. They're not head-to-head. But what's there based on meta-analysis suggests if you use number needed to treat as your benchmark, Esketamine is doing as well, if not better, in some of these studies than second generation. But again, I like to see both teams on the court head on.
Yeah, certainly true. It's fascinating to me. For years, what we've been doing is banging on the monoaminergic system. And as Steve alluded to, here we have glutamate, but also we have these other mechanisms. And we've got the neurosteroids that presumably work through GABA. We've got drugs that may be working through opioid system as well as other systems, the sigma-1 receptor system. So it could be, we know the biologic heterogeneity of depression. It could be we need these different arrows in the quiver, if you will. This has been a really fascinating discussion. I want to return to the guidelines and what future research areas need to be addressed in order to evolve these guidelines. What are some of the unmet needs that the guidelines weren't really able to nail down?
Yeah, I think some of these points that we just touched on, I think is really the priority of future research vistas. In other words, what should I give my patient in the algorithm after they've had, say, 2 failures? Is it a second generation? Is it esketamine or ketamine? I think the other point we brought up as well about how can I prolong the effect of ketamine or esketamine other than just keep giving them ketamine? Can I transition them, yes, to a psychotherapy, maybe internet-based or what have you? But is there some pill that I can give people? Again, I don't know what that pill could be. There's been a few that have been looked at. Nothing's got across the finish line yet. But we all celebrate the rapid alleviation of symptoms, but we want to keep people well. And that's still yet to be, I think, fully characterized other than just giving them more ketamine. I also think what's going to be really interesting as well in this area, which we talked about, some of these other areas, bipolar depression, PTSD. I think an area which someone should study is postpartum depression. I can't think of a situation where rapidity of onset could not be more important, et cetera, and safety of not just mom, but baby, of course. So that needs to be looked at. And I think to Steve's point earlier, what we talked about, this ongoing concern about the safety and the tolerability, we were, I think as healthcare providers, I think we're horrified by what happened with the opioid crisis. And I think we certainly need to be eyes wide open. We don't need to be given to paranoia and hysteria. We need to be eyes wide open. And certainly what's there is extremely reassuring that there doesn't seem to be that risk. But we, I think, need to have a better look at that over the long term with some large databases as well. There's others. Those are the ones that jump to mind for me.
Steve, do you have any final thoughts?
I'm just wondering, how do you chase, God forbid, that you get better on ketamine or esketamine administration to keep it going, other than repetitive infusions, which even themselves have their own problem. You use some of these new oral agents that are about to come out. And then, again, revisiting the wild card of, can you enhance the efficacy by what you do during that 90 minutes or 2 hours or whatever it is after the infusion is completed? To direct the brain's neuroplasticity towards a more permanent solution. So those are some of the big ones for me.
That's certainly fascinating, and I hope that everyone's enjoyed this wide-ranging talk that we've had through the areas of ketamine and esketamine and the new guidelines that have just been published in the American Journal of Psychiatry. Roger McIntyre's first author, Stephen Stahl, is the final author. Gentlemen, I really want to thank you for this really interesting discussion. Roger, thanks so much.
Oh, great to be with both of you and cover this topic.
Thanks. And Steve, thank you.
My pleasure.
Please stay tuned and join us for the other episodes in this podcast series, the PsychopharmaStahlogy Show. Thanks so much.
This episode was brought to you by NEI Membership. The 2021 NEI Synapse Virtual Half-Day Series is included with NEI Membership. Become a member today so that you can register for free for any or all of the monthly half-days, in which Dr. Stahl and colleagues will spend the last Saturday morning of each month sharing cutting-edge research and clinical insights on the topics most relevant to real-world practice. Don't miss out. Become a member today. Visit www.neiglobal.com to learn more.